15 to 20 minutes is talk about treatment pathways and really look at a practical approach to treatment. And just to keep in mind that the practice approach that I'm talking to you about is very U.S. based. And these are based on therapies that we have in the U.S. So you'll have to think about how to apply this in Vietnam or in your country. So I'm going to start with the patient. This is a 34-year-old man who was previously healthy, but now he has symptoms of postprandial abdominal pain, bloating, and abdominal distension. And he has urgent diarrhea approximately 30 minutes after eating. This started after a COVID-19 infection about 3 years ago and has persisted ever since. His testing is normal, so CBC, thyroid testing, C-reactive protein, calprotectin, celiac serologies. He had colonoscopy with the biopsies. All were normal, so he was diagnosed with irritable bowel syndrome. He was started on a low FODMAP diet and peppermint, but continued to have symptoms. So the question is, what do we do next and how do we approach the treatment? And Professor Hong already talked about the Bristol Stool Scale and trying to characterize the irritable bowel syndrome. I use this Bristol Stool Scale a lot because sometimes when you ask patients if they're having constipation or diarrhea, they may tell you that they're having diarrhea because they're going multiple times per day, but they're passing very hard stools. And so actually what they have is more of IBS constipation, but they're going multiple times per day because they're passing hard stools. So the picture will help you in terms of those diagnoses. I'm going to skip this here. One mention on the bile acid diarrhea is if you look at the guidelines, the diagnosis, the concept of bile acid diarrhea is very common in the U.S. About 22% of patients with IBS in the U.S. have bile acid diarrhea. But we don't really know what the prevalence of bile acid diarrhea is in Asia. If you are suspecting it, there are different tests that are available. And now there's actually a serum and a stool test that you can do rather than the previously 48-hour stool collection. Before I get into diagnosis, I want to talk a little bit about mechanisms. And again, the reason why I talk about mechanisms is to help you be able to implement some of these therapies in your practice, understanding what's driving some of the diseases. So the gastrointestinal tract has irritation locally in the lining where you have the nerves in the mucosa and the myenteric plexus. But so in addition to the intrinsic nervous system, there's also control from the extrinsic nervous system. So you can see there with the brain and the spinal cord, you have the sympathetic nervous system, which is that yellow there. That's your fight or flight response. And then the blue is the parasympathetic nervous system, that's rest or digest. So the autonomic nervous system controls everything that we can't control. So when you're sweating, you cannot control your sweat. That's your autonomic nervous system that controls that. Digestion, after you swallow your food, everything else is taken over by the autonomic nervous system. So if you have any disruption or a loss of that balance there of that sympathetic and parasympathetic system, it can lead to abnormalities in the digestive tract. We know that with irritable bowel syndrome that the pain is often triggered by foods. There's two mechanisms by which food triggers pain. There's one, the immune cells. So there's immune cells in the lining of the intestine. And most of the time, those immune cells are quiescent, so that when we eat foods, the immune cells recognize that those foods are friendly and do not become activated. But there are instances where these immune cells become overly reactive and then essentially create like a local allergy. And then there's non-immune related, where there are byproducts or osmotic effects of food that then trigger the nerves or the neurons in the digestive system. And when this perpetuates long term, it can lead to this dysregulation and this disorder of the brain-gut connection. But it's not starting in the brain, it's starting in the gut. So we've talked about the diagnosis of IBS. So you've diagnosed IBS, what do you do next? And the first step here really is education, reassurance, diet, and lifestyle. And what does it mean to educate and reassure? Oftentimes when patients have these symptoms, they often wonder why. Why do I have this? Why am I feeling this? Could it be cancer? Could it be something bad? And so a lot of what we do is reassuring patients that that they have IBS, and understanding the pathophysiology of IBS helps them understand that it's not in their head, but it's actually in the lining of their GI tract or the nervous system of their gut. So what are some of the dietary and lifestyle modifications or lifestyle modifications? There's diet, there's exercise, there's sleep, and there's stress management. So I'm going to start with diet because diet is the most common thing we talk about. And 60% of patients with IBS will have symptoms triggered by food or diet. And there's been a number of different studies that have looked at different diets or eating just small, frequent meals, avoiding fat, increasing fiber, avoiding milk. All of these things can be beneficial. There's been a lot of evidence about the low FODMAP diet. The challenge with the low FODMAP diet, it's a very intense, complicated diet to adhere to. And most of the studies on the low FODMAP diet really came from Europe, the US, and Western countries. So we don't quite understand how the low FODMAP diet helps or doesn't help in Asia. One of the things that we are seeing in the US and Europe is this condition called ARFID, or Avoidant Restrictive Food Intake Disorder. So it's an eating disorder, but not because the patients are worried about how they look, but because the food causes symptoms, so they're afraid of eating. And we see oftentimes patients then limit themselves to eating only fried foods, but they're still symptomatic. And you can see here that in patients with DGBI, up to 50% of patients will have an eating disorder. And why is that? Is that when they have symptoms, whether it's a recommendation from their physician or that they went onto the internet and decided to restrict foods themselves, is that then if they start restricting their foods but they still have symptoms, they start to think, well, maybe I forgot to eliminate something or I did something wrong, and they continue to restrict further and further. So there's a guideline that talks about how do you implement dietary recommendations, and before you start to recommend diet, you want to screen patients for an eating disorder or disordered eating. So oftentimes if I have a patient who has severe anxiety, diet will not be the first thing I recommend for them because I worry that they will develop disordered eating. So there's the traditional low FODMAP diet, which eliminates multiple foods. More recently, there's been discussion about the simplified low FODMAP diet, or low FODMAP light, which is elimination of only 2 FODMAPs, which is the fructans and the galacto-oligosaccharides. So you see below, the top is all of the with those foods with all the FODMAPs, below is more of the limited. And you can see with a limited low FODMAP diet that you do still get good responses. So it may be easier to start low FODMAP light, and then if they don't respond, you may consider increasing. Now, what about exercise? So I love food, and so I don't like to eliminate food. So if there's something that you can do without eliminating food, that would be beneficial. So this is a study that looked at yoga. So doing yoga for 75 minutes, 2 times per week, is just as effective as a low FODMAP diet. So imagine, either you limit all of your foods or you do yoga. I would choose yoga twice a week. So what's next? So you've done the diet, lifestyle modifications. Then what do? So you treat the predominant symptoms, so you want to make sure whether they have diarrhea or constipation. And so you want to treat the bowel symptoms. If they have diarrhea, you treat diarrhea. If there's constipation, you treat the constipation. And then you treat pain. So with pain, you can either use an antispasmodic or peppermint. And I prefer peppermint because it has fewer side effects there. And then there are therapies that are specific for IBS. These are prescription medications, and I'll go over these in more detail. So their first line is the diet lifestyle. The second are treating the predominant symptoms. And then the more specific IBS therapies. And then for patients who are persistently symptomatic, you can do brain-gut behavioral therapies and augmentation. So let's talk about the specific therapies here. So these are all the potential therapies that are available for IBS, for patients with IBS diarrhea. So you can see that, and this is the mechanism of action of these therapies. So there's the microbiome modulation with rifaximin or probiotics, the bile acid binding. So if you don't have access to testing for bile acid diarrhea, you could try a trial of polystyrene or colestid or cocellamine, the opioid receptors, antispasmodics, 5-HT3 antagonists like ondansetron or ondansetron, or tricyclic antidepressants. So these are all agents that are available that are specific for the underlying pathophysiology of IBS diarrhea. And then for IBS constipation, and again, very similarly, these are grouped into the mechanism of action of the therapy. And the reality of it is there's no head-to-head comparison to say that one therapy is better than the other. So you choose the therapy based on availability in your area, the cost. If it's too expensive, the patients are not going to take it. And oftentimes you need to choose more than one therapy. And if you do that, you want to choose therapies that have different mechanisms of action. So for example, if I'm going to choose a pro-secretory agent, I would not choose fluticasone and linaclotide if I'm choosing two therapies. I may choose linaclotide and physicotal because they're in two different mechanisms of action. And then for pain, I think we talked about this yesterday when we talked about functional dyspepsia, is these neuromodulators. So the neuromodulators really can help with visceral pain, whether it's in the esophagus, the stomach, or the colon. And we've heard multiple times yesterday and today that there's a lot of overlap. And which neuromodulator you choose really depends on what else is going on with the patient. So for example, if you have a patient who has IBS constipation and a lot of anxiety, I'll choose an SSRI such as paroxetine. If they have IBS diarrhea and they're not sleeping well, then I'll use a tricyclic antidepressant. So these are the things that you think about when you are choosing the neuromodulators. And then if they have no benefit or they're having side effects, I stop the medication. However, if they have a partial benefit but they're still symptomatic, you may want to augment or use a second medication. And what I've put here more for your reference here is that sometimes we choose the class of medication not so much because one works better than the other, but we're trying to leverage the side effect of the medication. So again, I mentioned that for someone with IBS diarrhea, I use a tricyclic antidepressant, and that's because one of the side effects is constipation. So if someone has diarrhea, I want to use something that will cause constipation. Another side effect is sleepiness. So if they're not sleeping well, I choose a medication that has the side effect that makes them sleepy. And so this table here tells you sort of a little bit of the mechanism of action, the GI effects, what it can do for symptoms, and some of the side effects. And what I typically counsel people on is because, we think of it as antidepressants or antipsychotics, so only the psychiatrist should use them. But really, of all the medications out there in the GI world, these are the class of medications that I prescribe the most. So what you want to do is choose one class of medication, one drug from that class, and get comfortable with it. Once you get comfortable with that drug, then go on to the next class. So just choose one drug from each class and step by step get comfortable with using it and then how to add them together. So what happens when you go all the way down to the bottom and you've done everything already and they're still symptomatic, especially if they have pain after eating? Then I take a step back and think about, well, what are the drivers of meal-related abdominal pain? And again, this is really the mechanism of action. So you can have, as I mentioned earlier, the local immune reaction, things related to the nutrients themselves. We'll talk a little bit about the carbohydrate intolerance or carbohydrate malabsorption. And this is a list of all the things that can mimic IBS. So these are all the disorders that can present like IBS, but when patients are not responding to your typical therapies, you want to think about these things. So I'm only going to focus on the carbohydrate intolerance and the food antigen sensitivity testing. And so you can actually, so if you look at normal carbohydrates on our small bowel order, you have the ability to break down the carbohydrates. And if you're missing the enzyme, it can then lead to malabsorption and symptoms. We can now take biopsies, and you can take this in the second or third part of the duodenum and send it for quantification of these enzymes. And again, this is US-based data. And what we found was that about 35% of patients have lactase deficiency, 9% have multiple enzyme deficiencies, and when you add it all together, over 40% of patients with IBS symptoms have an abnormality of an enzyme deficiency. And I would suspect if we did this in Vietnam, this number of lactase deficiency will be 80, 85, 90% there. And why would it be important to diagnose this? There's actually enzymes out there that you can use that are over the counter to help replace the enzyme that's missing, so that then patients can eat these foods. So for example, with lactase, there's lactate, which is a supplement, but there are others for sucrase and glucoamylase. Then I'm going to talk a little bit about these atypical food allergies. So this is this local immune reaction. And a lot of this work has come out of Europe. And what they did was they used confocal laser endomicroscopy at the time of endoscopy. And using fluorescein, you can see when the fluorescein leaks outside of the intestinal villi. And what they found was that 70% of patients with IBS had abnormal CLE testing. And then if you eliminate that food, so what you can use, you can flush the lumen with foods and look for this reaction. And when you eliminate these foods, their symptoms actually improve, and you see that here. We've started doing this in our patients, and this is a patient population that's very sick. So about 20% of the patients are on TPN or enteral nutrition. So it's a very sick population. And in this population, we found that 70% reacted to the food. And most commonly, wheat and milk, which is similar to what we saw in Europe. And what we found with this test, though, is that it helped change our therapy. So if they were positive, we helped them eliminate the food. If they tested negative, what we actually had them do was expand their diet. So a negative test is actually even beneficial because it helps you in terms of expanding their diet. And this is an older study, but it gets to the point of the immune cells. So pitotafin is a mast cell stabilizer. And this is a study that looked at using pitotafin in IBS diarrhea, and they found that pitotafin actually improved symptoms in patients with IBS. finish up with summary, just a reminder that IBS is a heterogeneous disorder with overlapping symptoms. You want to really focus on treating the predominant symptoms. And if you're treating the patients and they're not getting better, go back to the physiology and pathophysiology and think what else might be going on. I didn't get a chance to go through all of the potential things, but thinking about sort of the food intolerances. And sometimes, especially in patients with severe symptoms, that a multidisciplinary approach is necessary. Thank you.